Hello everyone and welcome to TCT 2022. I'm Ziad Ali from St. Francis Hospital and Heart Center, and I'm joined here by my friends and colleagues, Matt Price from San Diego, Alexandra Lansky from Yale, and Bobby from Beth Israel Deaconess, just local, didn't have to drive too far. And we're here to talk about the latest news, the latest data on shockwave intravascular lithotripsy. And I think the thing that people had really been waiting for here was the 2-year clinical results from the DISRUPT-CAD-3 study. And Matt, I'm going to go right to you to summarize what the major findings were of this updated analysis.
Well, let's first walk back to the initial publication, the initial results. So we enrolled about 350 patients with severe calcification in de novo coronary arteries, on average about 26 millimeters in length, with calcification defined as basically train tracks on the angiogram of more than 10 millimeters, and or if you did intravascular imaging, a calcium arc of more than 270 degrees. These patients in the single, non-randomized observational registry were treated with IVL and stenting, and we found that there's excellent stent expansion and fairly low and acceptable event rates at 1 year, particularly given the complexity of the lesions that were treated. And that in the end led to approval of IVL in the United States. So the question is, in these very complex lesions that are getting IVL, what are the outcomes at 2 years? Do you have a lasting result? So we found, we presented this morning, our 2-year outcomes. We had very good follow-up, more than 90% clinical follow-up. And we found that at 2 years, there was a sustained low event rates of both major adverse cardiovascular events, TLR, and target vessel revascularization, again, in the context of extremely complex lesions. So the rate of MACE at 2 years was about 18.6%, driven really by periprocedural myocardial infarction, defined as CKMB elevations more than 3 times upper limit of normal, so a biochemical result. And that was what drove the MACE endpoint, was those events around the time of the procedure. Now, there was not a QA of MI after 1 year. The rate of stent thrombosis was low, and after 1 year there was one episode of probable or definite stent thrombosis. And I think really the striking thing was the rate of ischemia-driven TLR at 2 years. So again, stepping back, average lesion length 26 millimeters, horrifically calcified vessels. The ischemic-driven TLR rate at 2 years was only 6.2%. So, or 6.4%. So really, I mean, we don't have a comparator. If you look at other trials of complex calcified lesions like the Orbit 3, and you're involved, we can chat about that. But certainly, qualitatively similar and pretty low given the complexity of the lesions studied.
So Bobby, Orbit 2 and DISRUPT-CAD-3 2-year results are actually pretty similar. So when you have these technologies, what are some of the differentiators that help you decide which one you're going to use when?
Yeah, it's a great question. Something that I think clinicians are grappling with as they get comfortable with new technologies as they're introduced. And I think that one has to think about what is the lesion that you're trying to get at, what are the characteristics of the calcium, and which modalities might be useful to address that specific type of calcium that you see. Is it superficial? Is it deep? Does it look like there are calcific nodules involved, or are there not? And then one has to think about one's own skill set and tolerance for risk. Yeah. I think that certainly there are complex coronary operators out there who are comfortable with all the different modalities, whether it be atherectomy in the various forms or IVL. But I think that there are some inherent advantages of a technology that allows you to do the typical things that we do with a wire and balloon that IVL offers. I don't think that one should be comfortable just knowing one modality. I think in a perfect world, one does get comfortable with all the different types of modalities to address calcium. But certainly what we're seeing in the DISRUPT-CAD data in the long term gives one, I think, a very positive view about the role of IVL in treatment of these lesions.
So, Alexandra, one of the things that's helps us decide what to use when is safety, and an overwhelmingly positive signal for IVL, maybe even somewhat surprisingly, has been the safety profile.
Yeah.
And the perforation risk is very, very low, and it's about actually 6-fold lower than it is with orbital atherectomy. That acute procedural result, right, how does that tie into the long-term clinical results in terms of decision making?
I think that's a really good question. Clearly what we've seen is, event rates, peri-procedural event rates, perforation, dissection, etc., up to, 3-5% with prior technologies. That drives up the acute results, right, in terms of MACE. Now, how does that translate into 1, 2, 3-year, 4-year outcomes? I would say that those are probably more, population-based. I mean, the diffuseness of disease, the extent of disease, severity of disease is probably driving those MACE event rates in the longer term. But there's no question that it's, it's increasing the events. So, I think we've got two things going on here. We've got a very high-risk patient population, and being able to address, upfront these types of lesions by reducing the acute complications, I think will reduce, the long-term MACE outcomes.
So, Matt, I'm going to come back to you with a hypothetical question. And the hypothetical question is, there was a sub-study within Disrupt C83, an OCT sub-study. If you had to predict whether intravascular imaging guided PCI, with all the mechanistic data that we know, with that calcium fractures lead to excellent expansion and are an important predictor of the final minimum stent area, would you predict that the OCT guided arm may actually behave better and have a lower event rate? Or do you think that these patients are just so complex that we might lose that signal? It's not a lot of patients, but...
I don't like hypotheticals, but I will answer this question. So you're saying within the OCT subgroup of Disrupt C83. Right. So I think there's a lot of biases in there who, certain sites were the ones who did it. I would say in general, I would guess that patients who receive imaging-guided intervention will have better outcomes than those who do not. However, I don't think you need to do intravascular imaging to do IVL and get a good result. In fact, it may actually be a great equalizer. That would be interesting to look at. But you and I are looking in a much larger cohort of patients in randomized fashion about intravascular imaging and outcomes. But I would still suspect that imaging will improve outcomes, particularly in this very complex lesion cohort.
So let me push you just on that a little bit more.
Okay.
On the angiogram.
Yeah.
What is it that you're looking for on the angiogram that says, I've prepped the lesion with the IVL?
Yeah, I think you and I may disagree on this a little bit. What I do is I deliver my IVL balloon, and I go until I get full expansion of the balloon itself, making sure that I'm correctly sized 1-to-1 to the vessel diameter. So let's say the reference vessel diameter is a 3L, I put in my 3L IVL catheter, I deliver my shocks, and at shock 27, my balloon looks fully, at 4 atmospheres, looks fully expanded and beautiful. I think I've gotten a good IVL result, and I would move on at that time.
What if you don't?
I would continue.
Keep shocking?
Keep shocking.
And then you've finished your shocks.
Yeah.
How important is the NC balloon dilation?
So, we have some data actually from the trial, right? So, the protocol of Disrupt C83 was that after IVL delivery, you did an angiogram. And if you had less than a 50% residual stenosis, you were instructed to put in your stent, right?
Yeah.
So the impressive stent expansion results, especially seen on the OCT, where we saw that on OCT, was in the setting of the majority of patients not getting further predilatation after IVL. They all got post-dilatation after the stent. Mm-hmm. So if I get full expansion of my IVL balloon and I've true sized it correctly, I don't do an NC balloon. I just go with my stent.
Okay. So, we're learning some interesting things about this mechanistically. So the IVL balloon has such low atmospheric pressure, it's really not designed to dilate.
Right.
It's really designed to facilitate delivery of energy into wall to facilitate cracking.
Right.
And then really it's the high pressure balloon inflation or the expansion at higher atmospheric pressure that separates those plates and allows you to see the expansion. So I think that's an important and interesting point to, at some point here, you need to see the balloon expanding. And actually I agree with you that that's probably the most important predictor of whether you're going to get a good result, is how the balloon behaves in the calcified segment.
Because
Peri or post preparation.
Right, because if at 4 atmospheres you're getting that shift already.
You're done.
You're done, because the stent you're going to go up to 10 to 14, 16 atmospheres. So yeah.
So Bobby, I'm going to talk to you about the bane of the interventionalist, which used to be calcium in general. And now we don't call it the bane anymore because we have more therapies, including shockwave. But I think the bane right now is nodules.
Yeah.
Okay. So calcified nodules seem to be increasing in their frequency, and they're a diagnostic dilemma because sometimes on angiograms they don't fit into the classic paradigm, right, Alex? Mm-hmm. And they're very difficult to treat. So tell us about, or update us about, the nodular data, and why don't you start with the clinical data?
Yeah. Well, just as a practicing interventional cardiologist, I think that most people are seeing and recognizing, I don't know if that they're going up in frequency in human beings, or is it that we're just recognizing them more, maybe some combination. But certainly we've become much more attuned to the fact that there is this very specific phenotype of calcium, which is particularly difficult to treat with typical balloon angioplasty and stents. It's the type of lesion that you balloon it and sometimes you end up not expanding it, or you see a balloon sort of push away from it. You put a stent in there because you think you're done, and then even on the angiogram, but definitely on the intravascular imaging, the imaging looks terrible because you've got basically a big protruding calcified nodule sticking into your stent, leaving it very far from a circular lumen that you'd want. And we know that when you get an outcome like that, it's associated with a high risk of TLR for sure, and stent thrombosis, thrombotic-related events in your stent. And so it's not something that we want to deal with. And so the question has been, how do we sort of treat that? And there are reasons to think that the typical armamentarium, things that we use to treat calcium, like atherectomy, may not be sufficient to treat lesions like that. You can certainly have nodular calcium that a wire for atherectomy is biased away from that, and then you not actually impart any sort of plaque modification or calcium modification to the nodule itself. The good news is that we're getting more and more data. I would still think the data is pretty thin, guiding us to how we should treat it, but at least there's new data that I can speak to about, that really you produced, Ziad, so it's funny to speak to you about it, from Disrupt C83 on the treatment of nodular calcium. And I would say that as a clinician who did not has not looked at it in the same way that you have with intravascular imaging, my sort of 10,000-foot view of the data would be somewhere sort of like this, that it looks like in patients treated with shockwave IVL, that whether or not you have nodular calcium in the trial, they achieved very similar stent expansion, minimum luminal diameters with their stent. And so the outcome afterwards, by all measurable sort of quantities that we have, look like calcific nodules were not associated with any worse of an acute outcome after treatment with IVL. And that's pretty remarkable, considering that I think before that we would have expected calcified nodules to really result in a worse acute procedural result. But I'd love to hear how you expand on that data and what your takeaway is.
Well, first of all, I think you summarized the data, beautifully, and that was that irrespective of the presence or absence of nodules, your minimal stent area, your overall stent expansion was very similar. So the presence or absence of a calcified nodule did not impact your acute procedural success. So I want to go to Alexandra for a second and ask about the diagnostic and interventional algorithm to a nodule. I think we've all, present company included, before this nodular data came out, I was going for atherectomy. And in fact, I thought orbital atherectomy probably makes the most sense because I can shave most of the nodule off. Does this data change your mind?
Well, I have to say I'm really impressed by all the mechanistic stuff that you're describing, and it does. I mean, it absolutely does. I think it simplifies, if you go out there in the community, right, and how many cath labs are there around the country? I mean, how many people are actually going in there and doing imaging to define whether they're, calcified nodules, whether they're chards going in there and they're going to prolapse into the stent? I don't think that, and I think that's the reason why we're seeing such high recurrence rates, because people are just not doing that. I mean, you're doing that, and the high volume centers are doing that. So in many ways, I think it changes things because it simplifies our approach more generally in how to treat these things. I mean, it's making it more simple, right? I mean, that's what I'm hearing.
Simple is good. No, I think what you said, Matt, is right. Like, I believe that, asking every interventionalist to, image a calcific nodule neither is going to happen nor should happen. That's why they're at TCT, because they're asking us who are doing the mechanistic work and who are interested in this field how to help them. But I think that the pragmatic approach, right now at least, is using IVL, whether it's nodular calcification or an eruptive nodule, it can't hurt. Mm-hmm. And it can probably help.
Yep.
So as a result, with this new data, really puts us in a strong position. So we're going to shift gears to some other incredibly important data that was presented at TCT, and that was the gender analysis of the PAD study. So, Alexandra, if you don't mind just summarizing for us the CAD gender data and putting in the perspective the PAD data, right. I think it could really help all the viewers.
Sure, yeah. So we were actually TCT last year, exactly a year ago. We looked at the patient-level pooled analysis from the CAD 1 through 4 trials. And we were interested to try and see whether the complication rates that we have seen, acute complication rates that we've seen with atherectomy, rotational orbital atherectomy, 5% dissection rates, flow-limiting dissections, perforations in female patients were seen with IVL. Given everything that you've told us, it was sort of a relevant question. So we pooled all these patients. We had about 630 patients, if I recall properly, about 20%. It's always a minority of females in all these trials.
If you ever need a decimal place, Matt remembers all the decimal places.
Yeah. So about 20, maybe 22, maybe 22 and a half. But lo and behold, we saw absolutely no complications. Very low rates, very similar between men and women, which we've never seen before. And then the other thing is you look at MACE, as your prior questions, MACE rates were similar between men and women. And then we tracked that on, that was 30-day outcomes. We were really interested in seeing the long-term outcomes out to 1 year. So we looked at that, and again, absolutely flat. So this was new to us. I mean, this is really a step forward. I should also put in context that as, it's male and females, but if you have, again, to the same point you're making earlier, calcified lesions patients with calcified lesions undergoing PCI, if you follow those patients, even after stent implantation, follow them 1, 2, and 3 years, their outcomes are really poor. And this has been looked at in female patients where we have higher mortality, higher MI rates, and higher revascularization rates. So it's a big issue. It's a big issue in female patients. So fast forwards to TCT 2022, we were interested in looking at the same question, but in PAD, right? So IVL is approved in PAD. They have a post-market registry. It's all acute data, but sizable. So we have like 1,400 patients.
Wow.
In PAD, the number of women is higher, so it was 30% female patients as opposed to making a little bit of progress on the peripheral side. And the results are the same. It's the same thing. So again, historically seeing much more complications, dissections, etc. Now with IVL, it's the great equalizer. So we're seeing very low rates, very similar rates of acute angiographic complications, dissection. And this is all by core lab. So, it's not site reported, it's really reviewed independently. and the acute results are great. So, this is a treatment for our female. We have a problem with our female patients, no question about it. And, for once we have a therapy that seems to be leveling the playing field here and improving outcomes. So, I've been talking about this for a long, long time, so I'm thrilled to see a treatment that actually helps and makes a difference.
So because I like asking hypothetical questions but not answering them, I'm going to ask one to Bobby. So one of the purported mechanisms by which there may be a gender difference in the coronary arteries is smaller coronary arteries that we use the same size burr for, so maybe there's more slow flow, smaller myocardial mass overall, which may lead to some of the complications. But on the peripheral side, the margin for error is larger, right? Yeah. The arteries are much bigger. So, your prediction on the clinical impact of these acute procedural results in the peripheral artery, will they have the same impact compared to CAD? And how important is that?
Yeah, over the long term.
Yeah.
It's time will tell. I think we'll learn about that. One might predict that the acute complication differences in the coronary circulation might have a stronger prognostic impact ultimately. But that's because I think the coronary circulation just has a less tolerance for complications and major adverse events than the peripheral vasculature. By the same token, we know that patients with peripheral vascular disease have exceptionally high rates of adverse consequences down the road. So, listen, if you can take a benefit and reduce a complication rate for women in particular who we know have poor long-term outcomes after PAD, and one of the mechanisms that you can do that is to avoid complications using the device just based on selection of a particular device. I think that any clinician is going to take that, and time will tell whether or not we see that translate to an improved long-term outcome compared to another device that might be associated with higher complications.
So Matt, there's like a million calcium algorithms, right? The British guys have one, I have one, they're all over the place. Yeah. Do you think we should have a separate algorithm for female gender? Should it just start with shockwave?
Well, I think one of the great things about IVL is it's an algorithm killer. In that we went through all these different nodules. We haven't talked very much about eccentric calcification, but it works there as well. Diffuse calcification. So I think it makes it much simpler. Now you throw in sex and gender, that even makes it even simplifies the algorithm further, that it's really a first-line therapy for complex calcification, irrespective of patient sex, irrespective of intravascular morphology, right? As long as you can get the balloon down.
So Alexandra, I heard a little rumor about a new trial.
Yes.
Can you tell us about it?
And I would answer your question right up front, yes. I think this should be the first line of treatment, because if we can minimize the acute complications, I think, and then just use atherectomy in those patients where we cannot, cross the lesion and use IVL first. So let me tell you about Empower CAD. We're very, very excited. This is being released and announced here at TCT. So this is addressing multiple things, and I have to say kudos to Shockwave for taking the lead. So we've been, as you know, we've been talking about outcomes in women, underrepresentation in clinical studies. Even in this patient-level pooled analysis that I talked about, 20%, well, maybe 22.5% were female, but it's always an underrepresentation, right? And we don't know what the best approach is. It's all pulled in, and the outcomes are the outcomes. So for the first time, we are going to have a prospective registry. This is a registry. It's going to be up to 400 patients, 50 centers, both US and Europe, where we're going to be testing an IVL first algorithm to treat women with moderate to severe calcification. We're going to have OCT, and we'll be amplifying your database so that we can, go into the mechanism of, exactly what you were talking about, and I think that's going to be very informative. So that's the trial. We're so excited about being able to do this. I think so. I'm teaming up with Margaret McEndergaard, and very thrilled to be working with Margaret. And I think another aspect of this, we've been trying to. The Women Power Group is trying to really pull in the leadership, which I think this is not exclusively for women, by women, but we're certainly going to be trying to pull in a lot of female leaders at sites, etc. Not exclusively. We'd love you guys to be a part of this.
Thank you.
But I think it's a very important study going forward. And look, we've identified a cohort of patients that are at high risk and where we potentially have a solution, and we're going to be testing it prospectively instead of saying, yes, well, here's this weak data, right?
Right.
And we can't make any definitive, treatment recommendations on that basis. So this is very exciting.
Well, congratulations.
Thank
I can
you.
tell you're very pleased, and
I'm very excited.
You deserve it, and so does the world. So to summarize, I think we talked about the Disrupt CAD 3 2-year data, which shows very robust clinical benefit, data that's similar to the Orbit 2 in terms of clinical outcome, which I think is very good scientific hygiene, but with a lower complication rate. So there is a potential benefit. I think, Bobby, we talked about calcified nodules, and the presence or absence of nodules really doesn't impact your minimal stent area, probably the most important long-term predictor of clinical outcomes. And then we talked about gender analysis, where shockwave shows benefits in the coronary circulation, and acutely the the procedural complications seem to be much lower. So it looks like our new algorithm is, if you can cross it, you shock it, and you think of other things afterwards. I'd like to thank all of my panelists. It was a pleasure as always, and we did it in 2021, we did it in 2022, so I'll see you guys next year to all of the updates on Shockwave IVL. Thank you very much.